Good afternoon, everyone. We're almost there. Thank you, Beth, for having me again. Thank you, Heidi. Thank you, Dr. Sharma, Dr. Kinney. I'm going to be talking to you today about transitions of care. Actually, also, I want to say that I just have to follow like the triple threat up here, so that's also not fair in the future. Thank you very much. Anyway, we're going to talk about transitions of care post-percutaneous intervention. How come it's not going? Yeah, that's what I'm hitting. Oh, I have no relevant financial disclosures or relationships. Okay, so let's just talk about the goals of my speech here and what we're going to go over. I would like to highlight how to complete and provide an effective handoff, achieving a meaningful discharge, and improving patient outcomes and their experience. And how will we do that? Of course, we have to hit on JCO guidelines, also the process that we have at Mount Sinai and its interdisciplinary approach, nursing handoff, and then we'll finish up with discharge and the important referral considerations, specifically cardiac rehab and sudden cardiac death prevention, which we'll go into more detail. So, Joint Commissions we're all familiar with, and Joint Commission defines transitions of care as a movement of patients between healthcare practitioners, settings, and home as their condition and care needs change. So how do they really measure that? And it really focuses and emphasizes on patient perception. I know there's many times that we feel that we've given adequate information to the patient. We hand them a very thick packet of discharge instructions, but it's their perception which is important. And it can be a little overwhelming for patients, especially first-time PCI patients. So we have to focus on their perception of their discharge. And the way we measure that is using Press-Ganey. We have 3 questions on the Press-Ganey that focuses on the transitions of care, and they are as follows. So during their hospital stay, do we take their needs and family needs and caregiver needs into consideration? Also, when they left the hospital, they felt like they had a good understanding of what they were responsible for moving forward to manage their health. And then lastly, when they left the hospital, that they clearly understood the purpose for taking each of the medications. And a lot of times post-PCI, the patients are coming in relatively healthy and leaving with a list of new medications. So it could be a little daunting for the patient. So it's good to reinforce and explain to them why they are going to be taking these medications. So this is an article focusing on quantitative data, which I know is very unique to nursing. And again, it's looking at the perception of patients and how they felt they were transitioned through their care post-PCI and then following discharge. And the study showed that the patients were very happy with their technical care, meaning that yes, they had a blockage and it needed to be fixed, and now we put a stent in and everything should be great. But they really felt lost through the process, and they had an unplanned patient journey across healthcare boundaries. They didn't feel like they had adequate instructions or information, and it was really difficult for them to integrate their new health information. Patients also needed help facilitating connections to community resources, which I know our case managers, social work, does a great job in doing that. It's not an easy task. And they also had trouble with their post-PCI follow-up appointments. And I know now there's a lot of our referring physicians that set up their post-procedure follow-up prior to coming in for the PCI. So that's a real sense of security for the patients, knowing that they have a plan of care in place. So this diagram here highlights the integral relationship between the institutions, the providers, and the patients, and how that morphs or transitions into handoff and eventually discharge. It just shows that we're all part of the process, and if one process is missing, then everything else falls through. So it's a continuity of care, and we need to continue it throughout the admission into the discharge. So what is our process currently at Mount Sinai? We love a good process here at Mount Sinai. Heidi, that's her favorite question. What is the process? And we joke, but it is true. I mean, it is important to understand the process. We have evidence-based guidelines that help to create our processes. And a well-thought-out process helps to prevent important patient safety issues that may otherwise fall through the cracks. Obviously, we need to adjust sometimes, but that's where our critical thinking skills come in place and make modifications as needed. Just to run through our quick process here, pre-procedure phone call, which Mary, who was our STEMI patient, she's very good at our pre-procedure phone calls that preps them for the procedure. They then come into the ambulatory care area where they get interviewed by the nurses and the NPs and review the plan of care there. If they're inpatient, the inpatient nurse will prompt them, and they also get visited by one of our fellows or NPs that will interview and assess the need for the PCI and consent them for the procedure. The procedural nurse does a pre-procedure interview to make sure that what is being reported in the pre-cath note is, that we're all on the same page. Looking at symptoms, their non-invasive testing, their lab work, and so on and so forth. Also, when the patient gets into the procedure room, we have another team approach, the nurse, the fellow, the tech. We all interview the patient, discuss, again, their symptoms, the plan of care, and what to be expected moving forward. A post-procedure debrief, and I want to emphasize that because I feel like sometimes we forget that we just did the procedure, we're very technical, but then we need to realize, what is our diagnosis? What am I going to hand off now to the next nurse, the next team that's going to be taking over care for this patient? If I have my own documentation to do, the fellow has their documentation, and then the technician, the CDT tech has their own documentation. We should all be documenting the same thing. I shouldn't be, if we did a right heart cath, I shouldn't be saying that we had normal right heart pressures and my fellow documented elevated right heart pressures, because he might be putting in his recommendations to start Lasix, and if I tell the handoff, the nurse that's going to be taking over care, that the right heart pressures were normal, it might be a little confusing as to why we're starting Lasix if I told her that we had normal right heart pressures. So again, just then post-procedure debrief, and then into handoff, and then eventually discharge. So JCO again. So JCO made handoff a national patient safety goal pretty recently, actually, back in 2006. I thought it would have been a lot later, but this is when they realized that there was serious issues regarding handoff, specifically with post-procedure patients. Because when you think about it, handoff can just be a huge game of telephone. And it is documented that post-procedure patients can sometimes receive up to 7 handoffs per shift. And I would argue that Sinai might even have more because of the amount of patients that we deal with and the amount of interdisciplinary teams that we deal with. So it's important that we create standardized practice and make sure that critical content is being communicated for every patient. And then we use something called SBAR, which I know we're all familiar with, but it's more modified because cath lab is a very specific discipline. So there's certain key points that we have to make sure they're being handed off from nurse to nurse, including access site, the diagnosis, the closure device, the bed rest, and so on and so forth. Actually, I want to go back to that last one because I want to just highlight a couple of things that I believe that can make handoff more successful. And JCO also highlights this as well. So it should be an organizational priority and expectation. And I think the importance of handoff is to try to limit the amount of handoff of each patient. Ideally, the patient should go from their procedure room to their final destination, and I know that's a very ambitious statement, but if you think about the amount of handoff and that game of telephone, critical information can be lost from handoff to handoff. Yes, we have standardization and process, but if we can reduce the amount of handoff within that patient's stay, the critical information is more likely to remain. And then also, again, the standardized of critical content and standardized tools, we use SBAR and it's a specific discipline, so there's certain things that we really do need to highlight that we don't let fall through the cracks. Okay. So nursing handoff, there's just some additional considerations for handoff that we incorporate here at Sinai. Obviously, it's patient-centered. We have our slogan, where you are the heart of the matter. We try to give face-to-face handoff, so post-procedure care, if they're going to our recovery area, I give bedside report. We're able to go over the access site, their vitals. We can talk to the patient right then and there and assess any needs that might need to be taken care of right away. We use patient liaisons. They're a huge help to us in order to integrate the family and the friends that are coming with these patients. Because there's such a high turnover, there's little time sometimes to integrate the families, so the patient liaisons really help to get everyone on board, because a lot of times the post-procedure care is done by the families and the friends that are there with the patients that day. And it's an extra set of ears, so it's good to always have the communication with those family members and friends. So also setting expectations, and I can't emphasize this enough. I think if we do a better job of communicating the patient's stay, what to expect, especially with same-day PCIs, I find that's very challenging, which is becoming more and more popular, and we'll get into that in the next few slides. But patients are being told, oh, you can go home today. When they say you can go home today, they think they're leaving in like 2 hours. So if we set expectations, it decreases the anxiety level. It lets them know that, yes, you are going to go home today, but we need to make sure that your labs are good, that your vitals are good, and that you are feeling well. So saying that they're going to go home in a few hours, I think sometimes makes them very anxious. And if we're able to give them a little bit of a timeline, it's better to set the expectations. And also using a team approach when explaining the next step and really talking your team up. I can't emphasize that enough. It really gives a sense of comfort and trust if you are talking highly about your coworkers and showing that you can work as a team. Even when the patient's going to another unit, we have our sister units, 7 East and 4 North, CCU. They're all great. They take great care of our patients. When you tell the patients that you're going to one of our sister units and that they're going to take good care of you, and you give the patient the nurse's name that's going to be taking care of you, it really gives them a sense of trust and comfort, and it actually aids in their experience overall. So I know this slide is very lengthy and wordy, but I want to just focus on the bottom part of the page. Obviously, when we give handoff to nurses, we're going to go over the basics of history, name, why they're here, the diagnosis, and so on and so forth. But sometimes we forget about communicating concerns, things to highlight or look out for during their stay while they're taking care of the patient that I'm going to be handing off. So any concerns during the PCI or post-PCI leading to post-care considerations, any EKG changes, chest pain, perforations. Perforations are not a common complication, but it can happen. A lot of times we could deal with it in real time and there's no real risk. But if I knew that a patient had a perforation during a PCI, I might be a little bit more aware of my vital signs and seeing that, well, my pressure is starting to drop a little bit. Let me notify the provider and maybe get an echo at bedside to rule out tamponade. We're trying to prevent care rather than be reactive to the patient's complications. Also, post-PCI plan of care, I think it's really important to hand off to the next nurse or who's going to be resuming care for the patient what the next step is for these patients. Are they coming back for a staged intervention? Will there be any medication changes? Like I said before, if there's somebody with elevated right heart pressures and they're not on diuretics, we might be considering that. So we might say, oh, we're going to start Lasix for this patient. Or if they had an elevated EDP, maybe we're going to consider hydrochlorothiazide. And also referrals, LifeVest, cardiac rehab, we'll go over that as well. Also, their platelet therapy, most of our patients get discharged on dual antiplatelet therapy, but sometimes there are circumstances where patients have single antiplatelet therapy, and that's sometimes when patients are allergic to aspirin, so we keep them on single antiplatelet with Brilinta or Effient, Also, short DAP, those are usually for patients who are going for a procedure fairly quickly that is more pertinent. And single therapy, meaning that they're just on something like Xarelto 2.5, which has been recently approved for cardiovascular health. And remember that this is your opportunity to ask questions, clarify, and confirm. It doesn't hurt to ask. If something doesn't make sense, it doesn't hurt to ask. So of course there's challenges to patient handoff. As I stated before, there are very high patient turnovers. It's very fast paced. We're one of the busiest cath labs in the nation. Our sister units are constantly admitting and discharging patients. It can be very challenging. So the handoff has to be standardized and it has to be detailed, but it also has to be efficient. We talked about it before, multiple handoffs per patient. So if we could limit the amount of handoff per patient, it'd be very beneficial to patient outcomes overall. There's also knowledge and experiences of the caregivers to take into consideration. And it's not to say that, the nurses don't know, but there's sometimes nurses that get floated from other units. They're new nurses. I don't know if anyone remembers first year as a nurse. It was quite a blur to me. We were just trying to get through the day. It's always a great idea to reach out to your fellow nurses that are not as familiar with the patients that you are dealing with, to just check in, and also giving report. Sometimes if I hear a new name, I'm like, oh, have you been here before? Oh, I'm fairly new here. So I'll be a little bit more detailed and report and explain a few more things to them. Also, language barriers, meaning that the patient has language barriers, and so getting a full report from them could be challenging, and therefore handing off that information can be challenging. And then also technical verbiage, meaning we use a lot of lingo in the cath lab, PTCA, DES, right fem, radial access with TR band. These are all this is all verbiage that sometimes, it doesn't make sense. We don't know what that word means. So if you don't understand what we're saying, it's always best to say, yeah, what does that mean? It doesn't, again, never hurts to ask. So discharge is the ultimate transition of care. And it's something that shouldn't be started when the patient's ready to get discharged. It should be started when the patient enters the hospital. We need to talk about their plan of care, and that includes the discharge. So with same-day PCIs, it's been quite common over the past several years. We've had incredible advancements in coronary interventions, stent technology, access, thanks to Dr. Barman, our increase in radial approach, closure devices for femoral access. Medication strategies have improved, peri and post-procedure, and therefore our risk of complications have improved. So this is great news for our patients. However, it limits our time with our patients and shortens our time to educate our patients. We have a very short window to have a captive audience. That's why it's important to start early and start the process before the patient's ready for discharge. I also want to point out with medications, I believe that's a challenging aspect to discharge, especially when it comes to statins, and I just wanted to touch upon that a little bit. Because many times patients it's an AHA recommendation, right, post-PCI, that they get discharged on a statin. But many times patients will report, oh, my statin levels are normal. Why I don't need this. Why would I want to take this? I know there's a lot of side effects to statins. So it can be very challenging. But there are many studies out there that prove that half of all vascular events occur in patients with normal or low-level LDLs. So we also know that cardiovascular disease is associated with inflammation, and we do check that in the procedure when we send procedure labs, and it's measured by CRP. So statins have an anti-inflammatory aspect to it. So it's not just for your statin levels, but also for the anti-inflammation aspect. But also, even though their levels are normal on paper, they're still creating plaque. So it's still indicating the need for an anti-lipid medication. And then also consults, so referrals. It's important upon discharge to assess your patients and ensure appropriate referrals are in place at the time of discharge. And again, start the process early. It shouldn't all fall on the last nurse that's going to be discharging and have to tell all this information to the patients. It's also, there's a lot of barriers to many of our patients, whether that be medical, socioeconomic. So identifying the barriers to discharge is very important as well. So I want to highlight with discharge the referrals, because this could literally mean saving a patient's life. I did a speech 2 years ago on cardiac rehab, and even then I didn't really know the effects and the benefits of cardiac rehab, and I know that my time's running out and I'm going to be quick. But to keep it short, cardiac rehab decreases mortality by 50%. 50%. So if you just tell your patient about cardiac rehab and they happen to go, you just decrease their mortality by 50%. It's in EPIC now. I'm just showing you the EPIC part. And then also sudden cardiac death primary prevention. And this is many of our patients, especially if they're coming in for a PCI, STEMI, and STEMI. If we just take a patient with some risk factors, so I'll just quickly go through this. So let's just say a patient has ischemic cardiomyopathy, meaning that a patient had a blockage that caused LV dysfunction, so their LV now is less than 40%. We revascularize them, so if you just follow down here, this way, we revascularize. They should be getting discharged on a beta blocker, an ACE or an ARB, and an aldosterone antagonist, like aldactone. When they are discharged, they should be considered for a wearable cardioverter defibrillator like LifeVest. After that, their EF should be reassessed in 90 days. And then if their EF did not improve in 90 days, they should be considered for ICD. Again, life-saving things that you as a nurse, a tech, NP could do to just decrease patient mortality. I had a patient just the other day that had a low EF, ischemic cardiomyopathy, for 3 years, and no one ever talked to him about his risk of sudden cardiac death and his need for possible AICD. And it's nothing on the patient, it's just, on his providers. He was referred by another hospital. It's just saying that things fall through the cracks, and you have to know that the buck stops with you. The responsibility falls on you. Don't let it fall on somebody else. You have a responsibility to your patient to provide appropriate care and protect them from harm. I know I'm going over. I'm almost done. So let's just reassess the goals of the presentation. If we communicate complete, clear, and effective handoff from not just nurse to nurse, but nurse to patient, then we will provide a meaningful discharge that will improve our patient outcomes and therefore the patient's experience. So in conclusion, PCI care should occur across a continuum from the pre-procedure phone call to signing the discharge paperwork. It all counts. The more cohesive care we can give a patient, the better the patient outcomes. And I would be remiss if I didn't just give a shout out to all the healthcare workers that, it makes me a little emotional, but really did their job to take care of the community during COVID. Thank you for all you did. For the CVTs, they created the PRONE team, single-handedly saved patients' lives. CCU, 7 East, 4 North, the whole Mount Sinai Heart team. Thank you so much for all you did during that time.